Welcome to the Virginia Hospital and Healthcare Association's Patients Come First podcast series. Podcast episodes are available on vhha.com and on popular podcast hosting apps, including Apple Podcast, Amazon, Spotify, and many others. We're a member of the Virginia Audio Collective and the World Podcast Network. Episodes also air Sundays at 9 a.m. on 100.5 FM, 92.7 FM, and 8:20 a.m. across Central Virginia, and 1650 a.m. in Hampton Roads. Please send any questions, comments, feedback, or guest suggestions to pcfpodcast@vhha.com. Again, that's pcfpodcast@vhha.com. Today we're excited to be joined by Dr. Louise Dominguez, a board-certified internist from VHC Health in Arlington, Virginia. Dr. Dominguez specializes in chronic disease management, organ compromise and failure, medical complexity, mental health, and migraines. He joins us today for a conversation about his work, as well as recent advancements in early detection and treatment of lung cancer. But first, Dr. Dominguez, welcome to the show. Thank you for being with us.
Thank you for having me.
Yeah, we appreciate you taking some time to chat with us today. We generally like to start these conversations just by getting to know our guests a little bit better. I did do some research, so I know a couple things about you, and I'll share some of that for our listeners here. We know that you earned your medical degree and a Master of Public Health from St. George's University School of Medicine for completing an internal medicine residency at Jersey City Medical Center. You then completed a fellowship at George Washington University, during which time you also worked for the U.S. House of Representatives Healthcare Subcommittee on Energy and Commerce. So you have a broad clinical experience as well as some government policy experience. Obviously, you're far more complex. Your story is far more complex than just those details and highlights on a resume. So if you would, just fill us in a little bit on your sort of unique personal story up to this point.
Sure. Well, I realized when I was in residency, I realized that there was kind of a lot more to medicine than what was actually clinically taught. And so I got really interested in healthcare finance and compliance because really those two things drive care a lot more than probably most people like to admit. And so that's why I enrolled in that fellowship and worked for the U.S. House, because Medicare actually sets a lot of the policies and procedures, and then private insurance follows Medicare's lead. And so I really kind of wanted to develop expertise in that area as well as the clinical area. That's what brought me back down to the DMV area.
Awesome. Yeah, well, I'm fascinated by your experience working with that congressional subcommittee, the House Energy and Commerce Committee. It's obviously really influential on health policy and funding. I wonder if you can tell us just a little bit more maybe about how that opportunity came about and the work you did in that role as well.
Sure. Well, in residency, I was actually elected as the House staff representative to negotiate our contracts with the hospital. And I kind of became the key liaison between our residency programs and administration. That was the first time that I really learned kind of what the C-suite's thinking is, and what their limitations are. And in residency, I decided I wanted to learn a lot more about that. And that's why I applied for the Health Policy Fellowship and came down here. While working for the U.S. House, I kind of had, 3 areas of expertise that I spent most of my time on. One was pharmaceutical development, supply chain, and pricing. The other one was Medicaid funding and all the different reimbursement streams that come through Medicaid. And then the last but not least, everyone's favorite, was simply coding. And that's what I did. And I've kind of been involved publishing, but also speaking, and even I taught a course on healthcare economics and trying to explain how the system actually works, because one of the interesting things is that we graduate med students and we graduate residents without really teaching them how the system works. They know science, they know anatomy, biochemistry, and they're able to treat clinical disease. But one thing that we don't treat is how the money flows and how that ends up dictating what is possible and what's not possible, which is a crazy thing to think about if you imagine, graduating from law school but not knowing how lawyers bill or how contracts work. But in medicine, we haven't really done that, and we're trying to start doing that now.
I want to shift gears just a little bit. We mentioned that one of your areas of specialty is chronic disease management, which gives you kind of a unique perspective on our main topic today, which is the advancements in early detection and treatment of lung cancer. Advances in medical science continue to lead to new treatments that can extend quality of life and extend life itself. When it comes to lung cancer, though, it does remain the leading cause of cancer deaths in the U.S., accounting for about 1 in 5 cancer deaths. So with that background, can you just tell us about some of the advancements in detection and treatment being implemented in systems like VHC Health and the impacts you've seen on patients because of those things?
Absolutely. And I will reiterate what you just said is that lung cancer is the third most common cancer that we get in the United States, but it is the primary killer when it comes to mortality from cancer. Number one, far and away, is lung cancer, over breast, over prostate, over anything else. Now, I guess you could say the silver lining of that is that we know primary cause for most of lung cancer, and that is smoking. Now, not 100%, but around 80 to 90% of lung cancer is attributed to current smoking or smoke exposure or previous smoking. The good news there is that there's something you can do about that, right? Like you can help counsel and coach people about how to stop smoking. We know that that is one of the hardest things people ever do, but we have medications now that we can also offer to help. Now, there is a small cohort of patients who still have a small amount of patients who get lung cancer that's not from smoking. So it's not perfect. But if you think about the biggest cancer killer in the United States, 80 to 90% of that is attributed to cigarettes. If we can make a dent in there, we can make a dramatic effect on lung cancer morbidity and mortality. Now, sometime within the last 5 to 10 years, the U.S. Preventative Services Task Force, which is the governing body that determines what preventative care gets covered by insurance, did pass a new regulation where lung cancer can now be screened for. And so the idea is if you have smoked or are currently smoking, and you have what's called a 20-pack year history, which is the assumption of 1 pack per day for about 20 years. Conversely, 2 packs a day for 10 years gets you a 20-pack year history, or half a pack a day for 40 years gets you a 20-pack year history. It's a weird way of measuring things, but that's our metric. Anyone who has a 20-pack year history of smoking is eligible for a CAT scan of the lungs. This is a low-dose radiation CAT scan. It's a quick one just to look for any abnormal nodules or masses in the lungs that we may have to follow up for. And you can continue getting one of those every year until you're out of the risk window. But the good news is, and that insurance now pays for this. And the whole point is, as with most cancers, the difference between finding it early and finding late is the ballgame. And especially with the mortality of lung cancer, by getting that screening when you turn 50, and right now that's the guideline. It is entirely possible in the future they might change that. This gets reevaluated every couple of years. For example, colonoscopies, everyone used to get them at 50, and they change it. Now we're starting to get them at 45. Lung cancer screening right now is at the age of 50. They might move that in the future, but you can get one, and you can get one every year until you're out of the risk window. And the good news is that insurance will pay for that. And again, the trick is catching it early. We know quitting smoking is hard. We know smoking causes lung cancer, along with many others. If you can get a CAT scan and find your lung cancer in the early stage 1 or 2, that can often be the difference between life and death.
I think it's so interesting. I mean, like you said, it's obviously very difficult to change some of those habits, but it's also interesting that such a significant killer in the U.S. is something that can be addressed like fairly. I mean, there's a pretty straight line to a solution, which is I think an interesting situation. So on that thread, you touched on it a little bit, but in addition to those screenings and things like that, I guess my question would be, what's your message to the public about the importance of taking preventative measures to minimize the risk of lung cancer?
I would say when it comes to habits and lifestyles and things that you can do, right? In general, we have nature and our nurture. And if something's in your genes, it's hard to fight that. It's going to come down the pipe at some point. But in terms of things we call the modifiable risk factors, things that you can do to try to improve your longevity and your health, quitting smoking is probably the biggest thing that you could do, followed by healthy eating and exercise. But quitting smoking is one of the most important things you can do to try to ensure a long life. people, once they quit smoking, notice dramatic improvements in their breathing and their exercise tolerance within 2 weeks. It literally takes only 2 weeks to start clearing some of that gunk out. So quitting smoking is one of the best things you can do for yourself and for your own longevity. And if you are having difficulty doing that, know that you are not alone. You can definitely seek help from your physician or your provider, because we now have medications to help people kick the habit.
Thank you so much for that message. I think that's great for folks to hear. We are nearing the end of our conversation, but before we conclude, we have a fun tradition on this podcast to close out our episodes by asking guests a pair of 2 mystery questions. And the way this is going to work is we have a list of 10. And to keep things interesting for our return listeners, if you could just pick 2 numbers between 1 and 10, and then I'll ask you those 2 corresponding questions as we close out.
All right, we'll do 3 and 7.
Okay, number 3. What is the most adventurous thing you have ever done? Big question.
Most adventurous thing I ever did was I was trying to get from Seville in Spain to Fez in Morocco. And I was young and traveling with my girlfriend at the time. And we just said, we're just going to backpack it and figure it out. We took a bus to a ferry, to a bus, to a train, to a taxi. And after about 12, 16 hours of travel, we actually got from Seville all the way down to Fez.
I love it. That is adventurous. What did you learn from that, if anything? Don't do it again.
Yeah. That, especially being a doctor, living in the area, like there's a big stress put on planning and thinking ahead. And I think what that made me realize is that a lot of times things can work out. You don't have to have a plan A and a plan B and a plan C. People are nice. Some people aren't, but a lot of times you can just figure it out by asking. And if you're okay, if you're not too type A and you're okay just kind of rolling with the punches, you can get to where you need to go.
You can get from Seville to Fez. Indeed. Okay. And number 7. What's one quality in others that you admire and try to embody?
A quality that I admire in others and try to embody would probably be some crossover between emotional IQ and insight. I love it when people are honest about what they can and what they cannot do and where they're coming from and what their own biases are. It really makes one of the fun things about medicine is that it's teamwork, right? I get to work with my own team and then of course with patients every day. And having people on the team when they're honest about what their capacities and comforts are and when they need help, really does wonders for managing expectation and getting everyone there at the same time and keeping everyone happy while doing it. A lot of the problems I've run into in my past have been when those kinds of expectations haven't been made clear or the communication lines aren't open, or people don't feel comfortable saying, hey, I need help, or I don't think this is a good idea. And so that is something that I love to find and seek out in colleagues and friends for that matter.
Yeah, a great point. Know thyself. Somebody said that. I don't remember who it was, but it's good advice, one way or the other. And with that, we have come to the close of another episode of the Virginia Hospital and Healthcare Association's Patients Come First podcast. If you liked what you heard, please make sure to leave us a 5-star review on Apple Podcast and subscribe so that you know when new episodes are released. Once again, Dr. Dominguez, we want to thank you so much for joining us. It was great to hear your perspective, and thanks for taking some time out of your day to speak with us today.
Thank you so much. Have a good one.